For our last session today, we will talk about facilitating our simulation scenarios. So we've designed that simulation, we've figured out how to keep it safe for our students and our learners. What do we actually do while we're there? So to present on that topic, I am very pleased to introduce two colleagues of mine from the University of Michigan, and they are the co-directors of our own simulation center. So first is Dr. Melissa Bathish, who is a clinical assistant professor and, as I said, co-director of the Clinical Learning Center and Simulation Lab at the University of Michigan School of Nursing. She's also a certified pediatric nurse practitioner and serves as the pediatric specialty lead at the School of Nursing. Dr. Bathish received her bachelor's and master's degrees and a doctorate of philosophy at the University of Michigan, Ann Arbor. She's a clinical educator and researcher focusing on simulation-based learning methods and technologies, specifically the development of innovative mixed reality technologies for skills and procedural training for nursing and medicine. Dr. Bathish is currently collaborating with Health Education England to scale this innovative methodology in the United Kingdom. She is also a Healthcare Innovation Impact Program Fellow at the University of Michigan and chairs the International Nursing Association of Clinical Simulation and Learning, or INACSL, Simulation Education Sustainability Special Interest Group. Our other co-director is Dr. Deborah Lee. She is also a clinical assistant professor in the Adult Gerontology Acute Care Nurse Practitioner program at the University of Michigan School of Nursing. She is certified as a family nurse practitioner and an acute care nurse practitioner. Her clinical practice is caring for critically ill patients at Borges Medical Center in Kalamazoo, Michigan. Dr. Lee is also a certified healthcare simulation educator and, as I said, co-director of the Clinical Learning Center at the University of Michigan. Dr. Lee received her bachelor's from the University of Michigan in nursing, a master's degree in nursing from Michigan State University, a postmaster certificate for her acute care nurse practitioner at Rush University, and a doctor of philosophy and nursing at Michigan State University. Dr. Lee is a clinician and researcher developing mixed reality educational materials to train medical and nursing students on various surgical and procedural skills. She is also collaborating with Health Education England to scale up that teaching method. And we're very pleased to have the two of them with us. They obviously wear many clinical and simulation hats.
Wow, Jess, thank you so much for that nice intro. We just want to say, we're so happy to be here. Welcome. Thanks for joining us for this workshop. And we're really looking forward to talking a little bit about facilitating simulations. So I think a lot of the, or some of the content that we are going to be covering today has been alluded to or has been touched on in some of the other presentations from yesterday and this morning. But all of these things join together to make a really good simulation-based learning experience. And so hopefully we can address these a bit more in detail. And I, similar to what Dr. Rossler did yesterday, I'm going to stop my video so that you can actually have a bigger view of the screen. So first, I'd like to review some of or highlight some of the objectives that we will try to touch base on during the presentation. So first, we'd like to discuss what facilitation of a simulation entails. We will review the standard of best practice in facilitation. We will identify the qualities of an effective facilitator. And then hopefully at the end, we will share some facilitation experiences that each of us might have had. So we've discussed, basically what is simulation facilitation, and we've discussed different types of fidelity in simulation. We've learned about scenario development, and now we have the scenario, and we are going to discuss the implementation of it. There are three main components of a simulated learning experience. They include a pre-briefing, the actual facilitation, and then a debriefing. So basically the pre-briefing is reflecting on actions before they happen. And then the debriefing happens after the scenario event is over. And so you are really reflecting on the action that happened. But we're focusing on number 2, which is reflection in action, or reflecting on what is happening at the present time. So what exactly is facilitation? First, it guides and it provides structure for the learners during the actual implementation of the simulation scenario. And it is understood that based on healthcare standards, so standards of best practice of simulation, that all of the learners have been given appropriate pre-learning materials, such as videos, journal articles, grading rubrics, etc. And it is the responsibility of the educator or the facilitator to do a pre-brief prior to the simulation experience that explains the details of the simulation. They review the objectives of the sim. They provide an overview of what the day looks like, introduces the learner to the environment, the mannequin, the equipment, etc., that the learner will be interacting with. And they let learners know that they are really, as the facilitator, trying to make the situation as real to life as possible. And in the simulation world, we sometimes refer to this as, quote, entering a contract with the students, where you are both contracted with each other on suspending their disbelief and acting as if it were a real clinical situation or environment. Facilitators do different approaches. They have different approaches and styles, but the facilitation should always follow guidelines and standards of best practice in order to meet the knowledge, skills, and attitudes of the learners that are involved in the simulation. Going the wrong way, I'm sorry about that. So facilitation, why is it important? And why is it important for the learning process? Facilitation can be challenging in that it is difficult to know when you are the educator and you're watching what's happening. It's difficult to know what the learner or the student is actually thinking in that moment. I don't know about any of you, but I'm definitely not a mind reader. So it's really good if we have students think about their actions and their thoughts and try to think aloud, think out loud, and give as much information in this scenario that they're doing in order for the facilitator to kind of be able to identify what are they thinking? Why are they doing this action? And if we don't do that, we don't reflect on these things, or we don't know and we can't identify it, there's parts of the learning experience that can be lost. So the benefits of reflecting, during the simulation and while you're facilitating it, is that it can really lead to new understanding of new knowledge, being able to adapt to a changing situation or changing environment. And then this in turn can foster the students' confidence and their security while they are in a safe learning environment, and that they're being supported by you as a faculty member, educator, facilitator, and their peers. And again, this should all be guided by theory and research or evidence. This figure is a graphic of Kolb's experiential learning theory, which is a core and fundamental theory in simulation. And I do know in Dr. Turkelson's presentation, she did list several different frameworks that are used in simulation education. But according to experiential learning theory, learners, they can cycle through 4 different learning modes. So there is a concrete experience, a reflective observation, the abstract conceptualization, and then the actual experience and experimentation in the per se clinical setting, so an active experimentation. And really the learners can enter this cycle at any time throughout the process. And in this circular fashion, since they can enter it at any time, the learning experiences can happen pretty quickly, or they could happen over time, depending on the learning mode and the learning style of the student. So experiential learning theory asserts that knowledge acquisition is enhanced in the environment or in environments where learners can explore, they can experience and assimilate new information in the context of what they already know. And then they can use analytical skills to reflect on their experiences. And then these reflections lead to changes in judgments, feelings, or skills of the learner. And for the facilitator, it's always important to understand that learners come to the situation and the simulation experience with their own frame of reference, their own thoughts, their own feelings, their own attitudes, their own past life experiences, or even past experiences in simulation that may not or may not have been psychologically safe. And these can become barriers to learning if the learner feels anxious, vulnerable. And Dr. Adams had a great presentation just prior to this on the importance of psychological safety in a safe environment. So Kolb's theory of experiential learning is just one framework to understand simulation-based learning experiences. And it highlights the importance of the reflection component in the learning cycle. So it allows students to process what may happen, what is happening, and what has happened. So with that in mind, we're going to talk about the facilitation standards for simulation. So INACSL, the International Nursing Association for Clinical Simulation and Learning, has developed several healthcare simulation standards of best practice. And again, Dr. Turkelson did mention quite a few of these standards. And I know this graphic is maybe a little small for you or hard to see, but there are 5 criterion that are put forth to meet this facilitation standard. So how are we going to approach our team of learners or participants for a simulation? And again, we have to think about diversity. We have to think about past experiences. So setting the standard of mutual respect and collaboration as you are facilitating a simulation is extremely important. So we have to think about how we should start the sim and how we should end the sim. So criterion 1, effective facilitation requires a facilitator who has specific skills and knowledge in simulation pedagogy. So attending conferences, peer reviewing each other, staying current on standards of practice, all of these things can help mentor us to improve our facilitator skills. So new facilitators can also watch how other faculty or educators facilitate a simulation, and they can take tips and pearls from each other. And there is also a developed and a tested instrument called the FCR, the Facilitator Competency Rubric, that you can use to have peers review your facilitation skills in different areas of pre-briefing and facilitation. And basically they can rate you from beginner to an advanced beginner and to a competent facilitator. So criterion 2, focus on outcomes and objectives for the simulation. They should for sure be appropriate for the level of the learners so as to not confuse or overload or frustrate the learner, so that they cannot focus on the knowledge and skills that they possess in order for them to be successful in the scenario. We talked briefly about criterion 3 a bit previously, in that pre-learnings and pre-briefings prior to the simulated experience really set the student up for success in achieving the objectives of the experience. And that really overall is what we are aiming to do. Criterion 4 addresses how the facilitator can give cues or lifesavers, which we will be talking about in more detail coming up, to the students at any time during a simulation. And we will go into detail with that soon. And then last, criterion 5 supports Kolb's theory of experiential learning, the graphic that was on a couple slides before this, in that students not only learn from the actual experience, but also after the experience through reflection, both abstract and concrete, and then continuing to reflect and apply that knowledge that they gained with actual experimentation through maybe additional simulated practice opportunities, or even through direct care patient opportunities. So does anybody have any questions about the criterion for the standard of practice before we move on? So what are the qualities of an effective facilitator? A facilitator should be able to draw out and build on the prior knowledge of the learner. They should really focus on a climate of trust and open communication with all of the participants, which then creates that safe space for learning to occur. Facilitators should use their own expert knowledge when appropriate to support learners in meeting the objectives of the simulation. So for example, you know, my specialty area is pediatric acute care. And so probably I would not have the expertise to facilitate a simulation necessarily in behavioral health or obstetrical nursing. So you really have to be, you know, use your own expert knowledge in order to facilitate appropriately. And then facilitators need to be very diligent in paying close attention to what is happening with all of the learners and participants in order to evaluate situations during the simulation and be able to coach the learners during their experience. As you can see from this figure on this slide, the educator really has many hats, where they wear many hats and have actual many roles during simulation that can positively influence that experience. So again, they need to be subject experts and adhere to simulation standards of best practice in order to meet the objectives of this experience. But as part of the facilitator role, the educator needs to also connect with learners in an understanding way in order to, you know, motivate them and encourage them to work through the simulation, meet the objectives, and have a good simulation-based learning experience. Additionally, the educator must coach the learners by helping them to refine their skills and the knowledge that they have, and give constructive criticism and feedback, again, in a psychologically safe space. So how do you know when to do this reflection and action during facilitating a simulation? So there are times during a simulation where you may be prompted. And one example is when the students, during the simulation, a student or students, they will pause or they will stop kind of doing what they had been doing. And this could indicate that, that they're trying to problem solve in order to work through the scenario. And in many cases, when you see the students pause, you can also see a change in their facial expressions or their body language. And I do know in some simulation facilities, in the rooms, they will put like a red line or something that indicates where if a student needs to pause, that they can go into that space, take a timeout, and try to figure out, you know, their next step in the simulation. Students may identify a simulation learning experience also as a group activity. So if students do pause or a group, you know, has questions, many times they'll work together through the situation and they'll collaborate with each other. And then they're able to successfully navigate the situation collectively. Facilitating a scenario can be easier if students are encouraged to think out loud as they work through a skill or scenario. That can be done, you know, during the actual scenario, or again, it could be during a timeout where a student pauses and goes to the timeout space where they can kind of walk through what they're thinking and be guided by the educator. I know in our institution, we really encourage students to think out loud, especially during summative evaluations, competency evaluations, or student checkoffs, so that we can understand their critical thinking and the clinical judgment that process that they're going through. And another situation is when students recognize maybe an abnormal finding or a new change in the patient condition or the scenario. And they have to use critical thinking skills in order to act accordingly. And if the students don't verbalize what their thought process is out loud, it could be, you know, it could be detrimental to the student. And, you know, we may not be able to pick up on why exactly they're doing with a certain action or moving in a certain way during the scenario as it unfolds. And it allows us, you know, to really get their rationale and be able to give them the correct rationale for how the simulation should play out. Which brings us to decisions. So decisions. Should we restore the scenario to its intended path or original objectives? Or would it be best to adapt maybe based on the activities of the students, adapt to a newly developed, you know, impromptu simulation that could still meet the objectives, but maybe in a little slightly different manner or a different direction? And there are different ways to manage these decisions. So once we identify when reflection and action is appropriate, how do we go about doing this during the simulation scenario? So there are two things that a facilitator should know and kind of have in their back pocket to ensure that the learners stay on track and meeting the objectives of the sim while maintaining fidelity as much as possible and ensuring psychological safety during that simulation experience. One of these is providing cues. And I do know, again, this has been addressed in other areas of the presentations, but providing cues or prompting or providing information for the learner to progress through the situation is one way to manage. And another is what is termed a lifesaver, to help manage unexpected events that could occur during a simulation experience. So cues can be given to learners in many different ways. They can be given through, you know, the faculty member sitting behind maybe the one-way mirror in the control room, and then they say something over the loudspeaker, and it's like the magical voice, you know, coming out of the ceiling. So you could do a cue that way. You could cue them through maybe changing the physiological state of the mannequin or changing patient trends. And you can also send a character or another participant into the simulated environment to maybe give lab results or new orders that will get them back on track. And then you can always, of course, call the learner on the phone. And it can also be guided by the reaction, the state, or the response of potentially a family member that is being role played. So this role player, this family member, they would get their role with the directions on how to interact or react, and what questions to ask, also to help keep the simulation moving forward in the right direction. And as mentioned, another methodology to manage unexpected events that occur during a simulation-based learning experience is the use of lifesavers to manage unexpected events that could happen. So these lifesavers, they can either be planned or determined before a simulated experience, where maybe during the development of a simulation, or if an educator has gone through and run this certain simulation multiple times, and they are able to anticipate a potential crossroad or interventions that may be needed because it's happened in the past or they're anticipated. But they can also occur spontaneously during the scenario that allows participants to complete that simulation. Similar to cues or prompting, the scenario lifesavers can be done also within the simulated scenario environment or room, such as, the student calling on the telephone to speak with a nurse practitioner or the physician. There can be patient voice or manipulation of the mannequin's vital signs. And then there are other things that can be a lifesaver that occur outside of the scenario, where the facilitator may have to give additional information to the learners to describe maybe a symptom that isn't being directly simulated. They may, say such things as, oh, remember or look at that skin rash on their right leg, to add additional context that will keep the learner on the intended path. You could also bring in a participant as a charge nurse or a respiratory therapist that could prompt them and change the course of the simulation in order to meet the objectives.
Melissa, this was one I was going to talk about briefly, where, if you have a participant that is in the simulation that's kind of monopolizing the scene, and the others aren't having time to think or aren't having time to reflect on what's going on, sometimes I will actually just have the person who is, leading at that point say, I have an emergency in the other room, and I actually do, let them step out, and it gives the other students a chance to participate. And then also, time to think and reflect, maybe they're not at the same level as the other person. So, and sometimes people are in a simulation and don't even realize that they're kind of monopolizing a situation. So trying to manage, and then how do you pull out kind of the wallflower, as we say, that is there. And so, asking particular questions, maybe even if it's coming from the magic voice, to help them reflect and understand what's going on.
Thanks, Deb. That's very true. And on this slide, it kind of goes into some of the things that you were just mentioning. So when are cues or lifesavers needed, and what are some issues during a simulation that can occur that you may need to pull these out of your back pocket? And these could be comprehension of the scenario. So maybe the students didn't get appropriate or enough pre-learnings or pre-briefings. There could be a mismatch with learner knowledge or competence, unexpected actions by learners or participants, where they might be kind of going down a rabbit hole, which Dr. Turkelson also mentioned, And then student behaviors such as the wallflower or the dominant nurse. So the wallflower is the student who's in the periphery and they, are trying to busy themselves with something little over by the med station or the sink because they're unsure of what to do or they're uncomfortable with it. And then there's also the dominant nurse or learner who takes charge and is doing everything in the sim. So, you do have to think about those student behaviors and figure out ways to use these cues and lifesavers to kind of work with the wallflower, get them off the wall, and then, have the dominant nurse maybe go out, be called out to take something to the lab, maybe a blood draw or something. And just an FYI, talking about flowers, the wallflower, the little picture there, that is the Michigan state flower and it's the apple blossom. So now we'll go into a little bit more detail, but comprehension of the scenario. So participants may fail to understand the scenario when, for example, maybe the motives and the actions of a role player are unclear or inconsistent. So they don't understand exactly, why what the parent is doing, why the parent is doing that, or why a respiratory therapist is doing something. They may be unclear on maybe the vital signs of the patient. They could be difficult to interpret. So an example of that is, a student could be trying to auscultate breath sounds and maybe the mannequin's breath sounds don't really sound like, what you have planned for the scenario. So it can get the students kind of mixed up, or maybe the student is not hearing or auscultating correctly because maybe they don't have the stethoscope in the right place and it's not over like the mannequin, breath sound speaker in the mannequin. The comprehension of the scenario could also be impaired if we don't give clear instructions before the scenario begins. So one example of this could be, a lack of information about the resources that are available to them during the scenario, or they're not oriented to the room, the mannequin, the equipment, and the actual environment and what you expect of them in that environment. So the scenario might also become too difficult for the participants, and this can lead to frustration. So we really have to be aware of this, as many educators and facilitators have a lot of knowledge and experience with patient care and can sometimes, set high or unrealistic goals, high achieving expectations without really even realizing it. So you have to be self-aware and just make sure that, the scenario is at the correct level for the knowledge and skills and attitudes of the student learner. Or conversely, the scenario might also be insufficiently challenging for the participants. So in that case, maybe the scenario would end really quickly and it wouldn't allow them to explore some important learning opportunities.
Melissa, I was going to say too here that when I work with the residents who are starting to come into critical care, and I was working with them this month, and what I tend to do is start in the room actually with the students, and then as they become more confident and they do repetitive scenarios and they get more comfortable, then I start to work my way out of the room. But really being there during the scenario to say, help me understand why you would think this, or help me understand what you're doing, really does kind of bring down the tension in the room and guides them through initially, but then they do build confidence over time.
Yeah, I definitely agree with that. That is a really good example. And even if the learners, are following the intended course of where you want the scenario to go, they could be progressing just really slowly. And then you'll be anticipating that there won't be enough time to allow the scenario to run its intended time frame. And there could be multiple reasons for this. So just because the scenario or a learner is going very slow in the process, this is not necessarily due to a lack of skills or knowledge, but what it could be related to is the participants' desire to avoid missing maybe an important piece of the scenario, or misinterpreting a lab, or missing some vital piece of information. And they want to feel competent, and sometimes they will take their time in order to keep that competent image. Conversely, though, participants can proceed really quickly, and they can take shortcuts. So they bypass some of the planned steps that we have kind of worked through in the development of the scenario, and they get bypassed. So one interesting example of this is, students they do talk with each other. So if you have a specific group of students, and let's say they're at the senior level, and all of them go through a code blue cardiac arrest simulation, well, you'll notice that at the beginning of the semester, it takes them a bit more time, and we have to do a lot of cueing and prompting and asking of questions and the magical voice over the ceiling. But by the end of the semester, the students have talked, and they already kind of know what the expected outcome is. So they get into it right away and don't even realize they're missing, steps and assessments, etc., because they're just cruising on. They know what the intended scenario is supposed to be, and they want to get it right. So, they want to be competent. And then in some scenarios, not all participants take an active role. So there may be, the primary nurse, there could be a secondary nurse, or you may play the role of another healthcare professional. And then there could be some of the participants that are outside of the sim room, and they're on standby to be called in for help. And sometimes the main participant, who could be nervous, right? So the student who is taking the role of the primary nurse, they could be nervous, or even the instructor really gets into the simulation, and then they forget that these participants are available and maybe waiting outside of the room or in another room. And in the worst case, that might mean that, a learner who has invested a lot in the preparation for the simulation through their pre-learnings and the pre-briefing, they're only active for a few minutes in the scenario, and that can be a bit disappointing. So we kind of like to spend some of the time that we have left and to end our presentation in sharing some examples of cues and lifesavers that you may have used or anticipate that you could use, just with your experience of what simulations that you've run and how they could be used to help the learner or the learners stay on track or reestablish where they are in a scenario. So think about cues as prompts for the learners to progress through the scenario, or lifesavers that could help manage an unexpected event, which could potentially change the course of the scenario. Keeping in mind, we must really keep in mind that it's meeting the objectives that were set out for it. And does anybody have any examples of how they might engage students, such as the wallflower, or take the reins away from the dominant participant who's in the scenario and is really the one doing most of the work? I don't know, Deb, if you might want to start, if you have examples.
Yeah, I was going to
yes. Hi.
Yes,
Hello?
go ahead.
Thank you very much for the presentation. Very interesting and really indicating. I know that being a critical care nurse, I normally use the cues, the new lab results as a cue for stimulating my student to learn or to assess if they really understood how to interpret arterial blood gases in the intensive care unit. So I normally give them the lab ABG, arterial blood gas slip, so that they can go through it as many as possible. Then there's a time when now I assess them on interpretation of the blood gas to see if they really understood what is it that they're supposed to do. Thank you.
Exactly. Bringing in things into the room such as, arterial blood gases or new labs that have been drawn, et cetera, that they can review and look at and it can kind of guide them.
And if they get it wrong in their assessment, maybe even, the voice from God, as we say, could say, maybe you need to reassess that if they start to get off track. So I know some students during cardiac arrest scenarios, they're not very comfortable with reading different arrhythmias. And so sometimes they will struggle with reading arrhythmias, and just giving them the time to work as a team and work together, I think is really helpful, and if you do have to guide them, that's okay. Does anyone else have, I'd love to hear if there's cues out there that people use that, maybe we haven't even talked about.
I mean, one cue could even be as simple as the facilitator, over, the loudspeaker, just asking if the student's not, kind of going in the right direction, or they're pausing and they may be confused, or they're trying to think through it. You could do something as simple as saying, is there any other information that you would like to add? And so that kind of gives them a cue. Oh, okay, I have to add something else, or let me, look at some other things, like let me look at the lab values, or let me listen to the lungs. And so that kind of lets them know you're missing something without saying you're missing something.
And I do think every group that goes just slightly different. So you have to be flexible and ready to adjust on the fly, and paying attention, obviously, to what's going on.
You could also, oh, go ahead.
Oh, I was just gonna say, any other comments or thoughts on facilitation as well? I mean, I think we've had a nice coverage of the different standards so far today.
I mean, very easily you could also, make changes in vital signs or some physiologic indicator of the mannequin that would be projected onto, the monitor. And a lot, I mean, I've seen it a lot where students can be just so focused, one track mind, focused on one skill, that they're not really even looking at the monitor. So we will have changed vital signs where like an oxygen saturation is down to, 80%, and they still have not looked at the monitor. And so sometimes those can be very helpful, but you may have to say, is there anything else you want to look at or think about?
I have a question, since I don't do ones with monitors as much. Can you make the monitor beep? So if nobody's noticed the heart rate or nobody's noticed the saturation, can you drop it to an alarm level and make the alarm go off?
Yes, you can. And if you are using a certain, monitor, et cetera, but some of our monitors do not beep. they'll kind of blink. So the students aren't, cued by that alarm.
It's a good idea though, Megan. If you could drop it below 70% on an O2 sat, would it then, alarm faster or more frequently? It's a great idea.
I think ours flashes more so.
So you still have to have the voice come out of the ceiling and say, you might want to check your monitors.
Exactly.
Yeah.
You could also have somebody from the outside. So maybe a charge nurse comes in and asks a question that kind of gets them thinking about, oh, maybe I should do that. Or the nurse practitioner comes in and asks a question on the status of the patient that you're trying to get the student to notice. And then the student's like, oh yeah, I need to do that.
Here's a question. Could you please give us an example of a scenario to integrate cultural diversity and evidence-based practice in clinical settings? These are two issues that are very important because it is an expected outcome of the learning unit. So I'm trying to think of cultural diversity, one that we have used.
We could ask Jessica Marsak. So Jessica has been working with us on diversity and simulation. So Jess, maybe you could just highlight what we're trying to get funding for.
Sure. So there's a couple of ways that we can think about diversity and simulation. The first is very basic, which is to have, if you have these materials, to have a variety of mannequins that represent diverse populations. So when we did a audit of our own mannequins, we realized that most of them were Caucasian. And that's really not representative of our patient population or our students. So we are aiming to get some more diverse populations, and depending on what company you order through or what product it is, there are different, they call them skin tones or skin colors that you can order. But that isn't enough. So what we used to do is do very sometimes specific simulations that were about cultural diversity. So I remember an example, I don't think this is one that we did, but from years ago, where a patient wanted to light a candle in the hospital as part of a ritual, and it wasn't allowed because it was a fire risk. And so the point of the simulation was to deal with that cultural clash. It seems that what we are shifting to is to make sure that culture is really a part of every simulation that we do, that every simulation represents a diversity of patients, that are the names that we use in our simulated patients aren't always Jim Smith, that we do something a little bit more complicated to challenge our learners, that we have a cultural issue be a small part of the simulation, but not the whole thing. So maybe our patient has trouble with English, and as part of our simulation, our student has to engage with interpreter services. And so in that way, I think you can get at more aspects of evidence-based practice than trying to cram it all into one simulation on that topic.
That's great. Thank you, Jessica.
Mm-hmm.
Anybody else?
Okay. I see a hand raise.
Yes, I think there's something that is just bothering me. And let me just pose this question because I want to bring myself from the level where I am. And my question is, what is the difference between simulation and task teaching?
So we in the graduate program do a lot of task training where basically we're teaching the students how to remove a mole or put in sutures on just it's what we call task trainers, or do a pelvic exam or prostate exam. So is task training or procedural training versus doing a full simulation where they have to look at, you know, lab values and do critical thinking along with their scenario. That's how I see the difference.
Thank you, because at least now I'm kind of like bringing myself to the level, because I'm like, whoa, what have we been doing? So you can incorporate both, because I think we are at the level where we are doing a lot of task training or procedures, even for the undergrads. But then it's like move beyond just procedure, but integrate learning. Thank you so much.
Yes, I would agree with that. So you can do scenarios or simulations where the student has to determine then, does the mannequin need intubated, or does the mannequin need a central line? Maybe it's a Foley catheter. So yeah, helping them to critically think through the different procedures that need to be done, but then also doing the procedure during the simulation. And the undergrad program is actually very good at doing that.
Thank you for that question. That was a good question.
Mm-hmm.
Anyone else have any examples or questions?
I think it was a good day of content. This was a lot of information everybody's gotten today.
Yeah, I agree.
In closing, actually, to build on that last question, do you all have an example of a favorite simulation that you've created that you could briefly describe, just sort of as an example of how you do go incorporating some of the skills along with the critical thinking and communication?
Deb, maybe touch base on the your escape room.
Oh, I was thinking of a couple. Yeah. So we did actually do an escape room for the graduate nurses, where I think it was graduate nurses we did it for, had to actually work within the room to find where there were mistakes that were happening. And as they would find the mistakes, and they would find a clue to the next part of the scenario. So we actually hung the wrong dosage of antibiotics. And as soon as they would see the wrong dosage of antibiotics, on the back of the IV bag was a key, and a key that opened, you know, a lockbox that gave them more information, lab data and EKG and stuff. So that was a fun scenario to let the students unfold. And then the other one that I think I really enjoy is an IPE simulation that we've done. We do it with the medical school, the dental school, social work, and school of pharmacy, along with nursing. And it's really more of an ethical issue in the scenario. So we do have a prisoner who is coming into the hospital to be evaluated. He's actually at end of life, or becomes at end of life. And so what's the decision making? Who gets to make decisions for this patient? You know, is the ward of the state in charge? Is it the family? Can we contact family? Are we allowed to do that? And we did see this a lot during COVID. We had, we had 600 prisoners actually in one of our local facilities get COVID. And so we had to go through special appropriations to be able to communicate with the family and give updates to the family. So there definitely can be some really good ethical content inside of simulation as well. How about you, Melissa?
Yeah, those are two really good examples. And I think for the most part, a lot of our simulations obviously correlate with the courses. So we take a specialty area, let's say pediatrics, and we focus on an area of that specialty that should be addressed, and that the students will most likely see in the clinical setting. So respiratory distress, asthma, etc. And I know our OB obstetrical specialty, they focus on postpartum hemorrhage, because that is something that they can see in the clinical setting, but they may not be able, in their clinical time to actually experience a postpartum hemorrhage. So they do get that experience in the sim lab. So a lot of our simulations are focused specifically for the specialties.
Sure. I see Patry had a second part to that question about what kind of content to provide before the scenario or in pre-briefing, which will actually be our first session tomorrow. That'll be my session. So hopefully I do a good job of answering that question. We're going to hold on to that one until tomorrow morning, but we will talk about that. And then I see one more question in the chat. Could you please give an example of using simulations for graduate students?
Gosh, the pediatric primary care and acute care students do a fair amount of simulation because they don't have standardized patients, or we don't have standardized patients that are hired that are young. And so I would say they do a fair amount of emergencies, asthma, bronchitis, different things that the students have to figure out with the faculty, either in the room. A lot of times they're in the room and changing the vitals, or outside of the room. So cases that you wouldn't necessarily see, but that you should see before you graduate.
And our midwifery students also do a lot of simulations. And so they use task trainers and some of the high fidelity simulators to, work with the midwifery students on birthing a child and how to take care of, the newborn in the isolette or under the warmer. So we use different mannequins, and their names are Victoria and Noelle, and yes, and we have a Sophie and Mom. So, but those are more high fidelity.
Mm-hmm.
I do see an expansion on that question too. So giving an example of using simulation in graduate students, we need to use simulation to prepare basic skills for graduate students from several countries before starting practicum courses at the graduate level. So it sounds like maybe the idea of using simulation to bring everyone to the same starting point. So maybe touching on the idea of boot camps.
Mm-hmm.
So yeah, we do offer at our institution what we call a boot camp, and it is a very concentrated session over a couple of days where students can sign up to come into our clinical learning center and have the ability to practice, any of the skills that they will be tested on at the beginning of a school year. And I do know, for the graduate students, you have procedural training courses and opportunities with open lab time for practice as well.
We do. And actually, before our students start into practicum, then they have to do a clinical competency test, which we actually have next week. So they have to see a patient, do a focused exam, and basically do a full documentation and also a oral sign out to our faculty so that we know they're able to collect information, do a physical exam, document appropriately, and do an oral report prior to being able to go into clinic. And if they don't pass that or don't do well on that, then we remediate them until they start clinical.
Great, thank you. Chair Point, did that answer your question? Great. Okay, it is just about noon here. So in the interest of respecting everyone's time, I know it's very late in the day for some of you. Thank you, Drs. Lee and Bathish, for that presentation. I think that was really good.